Hello and welcome to another lecture for my class, PSYC 770, Psychological Testing and Assessment. As you can see from the title, this one is going to concern the use and the interpretation of the RBANS-Update. That is, the most current version of the Repeatable Battery for the Assessment of Neuropsychological Status. Now before we get started, a few points to consider. First, clinical neuropsychology is a very complicated domain of practice. It's a broad area of assessment that includes a variety of different referral questions, a wide variety of different tests or measures, and a wide variety of different client populations. And there are even sort of broadly these different approaches that people take to testing. Now, in past lectures, I've made a distinction between a more traditional approach to neuropsychological testing and a somewhat more contemporary approach to neuropsychological testing. And I thought in this lecture I should probably explain a bit more about what I mean. By a more traditional approach, what I mean is one in which a neuropsychologist selects from a large range of options for tests based on the particular client that he or she is working with or the particular referral questions that he or she is trying to answer. In contrast, in the contemporary approach, the neuropsychologist for the most part uses a standard battery of tests for most or maybe even for all of the clients that he or she sees, or for most or all of the referral questions that he or she gets. In the traditional approach, the neuropsychologist has selected those personalized or individualized set of tests. He or she administers them to the client and then interprets those tests based on his or her training and experience, or maybe based on independently published norms for those tests. So you could imagine I'm a kind of a more traditional neuropsychologist. I've got a client sitting in front of me and I administer a set of tests that I think are the most important or the most relevant for that client, and I interpret that client's performance based on what I know about how people typically perform on those tests, based on my training, based on my years of experience, or maybe if I want to kind of further explore the issue, I can look up independently published research that gives norms for the trail making test, or the Wisconsin card swing test, or so on. Now, in contrast, if I'm the more contemporary neuropsychologist, I might just use the published norms in the back of the test scoring and administration book that comes from the publisher of that battery of tests. So rather than using my own judgment or experience or referring to independent research, I just flip to the back of the book or use the appropriate computer program if it's a computerized scoring system, and I use the norms for those different tests in the battery that come from the test developer, come from the people who developed and published the test. This traditional approach in some ways, of course, is more flexible, it's more personalized, it's more idiographic in the sense that it is an approach to testing which focuses more on the uniqueness or the individual features of the particular client. In contrast, the contemporary approach is more standardized, more nomothetic in the sense that it takes each individual person and compares them to the broader group of people within their age range or within their client population or so on. So these two broad approaches, I think you can see in neuropsychology. I call one of them traditional in the sense that it is literally just historically older. I call one of them contemporary in the sense that it's historically younger or newer. I put little asterisks up there for an important reason, and that is that in practice, neuropsychological assessment probably involves both approaches. So if you're a practicing neuropsychologist, it's very likely that you will be somewhat traditional in the sense that you'll be thinking carefully to select tests that help you answer the right questions for the particular referral. I mean, that's true of just about any good test administrator, whether you work in neuropsychology or you work in some other area of testing. But you'll probably, at least nowadays, be taking advantage of high quality published test batteries, especially in neuropsych, because you're often trying to test a bunch of different domains, and it's just convenient to have a nice kit, a box of tests that you can open up, and it's going to give you most of what you look for in your neuropsychological assessment. So two broad approaches. I make a distinction between them, but then I kind of walk it back a bit to say, hey, look, in practice, there's probably a bit more blurring or overlap here than you might guess from this sharp cut that I've made between the two. So anyway, neuropsychological testing, complicated area of domain. There are lots of good resources out there. In previous lectures, I've highlighted the Essentials series. There are a number of Essentials books that are relevant for neuropsychological testing. You can see a few of them here. Some of them are for broad areas of neuropsych testing. Others concern particular tests. The NEPSI that you can see there is just one standardized neuropsychological battery. They don't, at least the last time I checked, they don't have one for the RBANS, or at least not for the RBANS-Update, so that's unfortunate, although new books come out all the time, and so perhaps when I finish this lecture and I check Amazon, there'll be a new one, in which case I'll probably go out and buy it. I just really like the Essentials series. They give you a really great mix of an introduction to a test or a testing area, some of the important theories, how to administer the various tests that are used in that area, and then some very good advice on how to interpret them. I like those a lot. Okay, so you might be wondering, neuropsychology is such a broad area, why focus on the RBANS, especially given that there isn't a published book from the Essentials series on it, so maybe it's just not that important to test. Well, it is a quite important test battery. I think it's also a really good teaching example for neuropsychological assessment. It's a good example because it's a relatively short battery, it's relatively simple to use and to interpret, and I think it gives a good kind of illustration or offers a good example of how a neuropsychologist might go about administering a set of tests and then interpreting them so as to answer some important questions that might commonly come up in the area of neuropsychological testing. So it's really, I'm not a neuropsychologist, but I do have some training on neuropsychological testing, and the RBANS was one of the first tests that I learned, and it's one of the ones that I teach in my class, partly because I think it's just a great example for teaching. And I hope if you're familiar with the test, you'll agree with me, or if you're not and you're just watching this video out of curiosity, by the end of it, you'll think, oh yeah, it's a pretty good example for what neuropsychological testing looks like. So again, it's relatively simple, and by simple I mean it's designed to be sort of quick and easy and useful to administer, to score, and to interpret. It's designed to take about 20 or 30 minutes to administer, and to have relatively limited motor demands associated with it. So unlike, say, for instance, the Wechsler Adult Intelligence Scale, which has a block design task where you have to move your hands, of course, to manipulate the blocks, there really aren't a lot of hand movement manipulations necessary for this assessment. That's useful because often when you're working in neuropsych testing settings, you're working with people who are older, or people who have sustained head injuries, or people who might, for all sorts of other reasons, have difficulty with motor outputs, and so it's handy to have a test that doesn't require a lot of that. It's designed to give to measure broad neurocognitive domains and to allow you to generate a profile for each patient, sort of a run of rises and falls that can be useful for screening purposes, and especially for detecting and describing dementia. And again, a lot of neuropsychological testing occurs in settings where we're working with older people, and one of the referral questions that you would get for clients in those type of settings is, does this particular client likely have dementia, and if they do, what sort of dementia seems most likely for them, and so on. So this is a test that's designed to work well in those type of settings. You may have noticed, if you're listening very carefully, that the R in RBANS stands for repeatable. There are different versions of the RBANS. I think in the update there are now 4 separate versions, so the same test with the same subtest, but each subtest has different questions on it, such that you can administer different forms of the RBANS over time without having to worry a lot about people remembering the answers from the previous time they took the test. That repeatability is really handy, again, because you're often doing neuropsychological testing in settings where people are showing evidence of degenerating functioning. Someone is coming back, an older person is being assessed repeatedly over months or years, and unfortunately we expect that some of their faculties may be declining over that time. Or you might be working in kind of a cognitive rehabilitation setting. Someone has sustained a head injury, maybe they have some sort of traumatic brain damage, and they're being treated, and over time hopefully their functioning will be improving. So you want to be able to administer a test that can
repeatedly over time and track change, whether it's change in the positive direction or change in the more negative or degenerative direction. The repeatability is really handy, and it's clearly one of the nice features of the RBANS, one of the important features. That's why they put it very prominently in the name. Anyway, all that being said, just last point to consider, or I think it's more or less the last point to consider, as is the case with so much of what I talk about in my class, I teach a pretty basic approach to interpreting this test that emphasizes successive levels of analysis, from overall functioning to profile analysis to subtest analysis. That overall approach is more or less the same approach that I take to most types of test interpretation, and it's consistent with what's published in the RBANS manual. So I'm not giving you today anything that I've made up myself. It's basically what the company teaches you to do with their test, and I'm perfectly happy to follow their lead on this. Now, the RBANS is published by Pearson PsyCor, like many of the other tests I've talked about in this class, and because it's published by them, it can be used with their interactive software to allow you to more easily administer the test and more quickly score and interpret and report the test. Now, I don't have access to this software. In our department, we never really bothered to buy it because it wasn't really necessary for teaching a class on testing. But I have read on their website that it does have a number of cool features. One of the things I think is most interesting is that it includes subtests from other tests. So if you're doing an RBANS, or more broadly, if you're doing a neuropsych assessment and you want to administer parts of the RBANS, you can also, using the software, call up subtests from other tests, like the Wechsler et al. Intelligence Scale. You can also administer parts of it on an iPad, which is probably pretty handy if you're in a clinical setting and you don't want to worry about loose paper, or you want to have ease of administration. So cool features. I can't say I've used them from personal experience. I haven't. I've only ever used RBANS on paper, like with most tests I've ever used. And to be clear, this is one of those tests where you don't need the software to use the test. The software is certainly, or it seems like it would make things very easy and convenient, but like many other tests we've talked about, like the Wechsler test, this is one where you can administer the test, score it, do the necessary calculations for interpretation by hand. It's really not that hard to do. In fact, in many ways, it's much easier than some of the other tests we've talked about this semester. Now, again, just one or two more points before we really get into it. I know I mentioned this in many of my lectures, but it's worth mentioning again. We have to remember our ethical standards when we're doing any sort of psychological testing and assessment, and that certainly applies to neuropsychological testing. One of these, from ethical standard number 9, bases for assessment, is that we should make assessments and we should offer interpretations based on sufficient information. And any test, whether it's an RBANS or a portion of the RBANS or some other neuropsychological test or some other psychological test, any one test by itself is not an assessment. The test is the tool, the assessment is the product that you, as the skilled and trained and licensed clinician, produce with that tool. And to be clear, or to be a bit more specific for today's lecture, the RBANS alone is probably not sufficient for a complete neuropsychological assessment. I give it as an example for teaching purposes for reasons I've previously described, but the RBANS by itself isn't a full and complete neuropsychological assessment, or at least it probably isn't in most settings or for most uses. It may be useful for screening purposes, it may be useful to help you choose other tests or make referrals for further testing. It's just a tool, and so remember that. And that broad ethical standard applies really to all testing, but as I said already, it bears repetition, especially in the area of neuropsychological testing, where, as I previously said, it's complicated. There's a lot of tests, a lot of questions, a lot of different types of clients. Don't mistake the test for the assessment. Boy, that's a lot of preliminaries, and now I'm through with all of them, and so we can get on to the proper lecture. I'm going to begin with just a quick note on how to complete the record form. I'm going to go through my sort of successive levels of analysis to suggest how you can interpret the test, and then I'm going to conclude by briefly noting how you can put all this stuff together.
And once again, to be clear, this is the approach to test interpretation that is advocated in the book that is published with the RBANS, and you can find material online if you just go to Psycor's website and search for the RBANS. They have a little bit of supplemental material there you can look at. Okay, let's get going. First off, completing the record form. Okay, if you have a copy of the RBANS, you can open up the box and pull out one of the record forms. If you don't, you can just play along in your imagination. The record form has a front page, and the front page is your space to write down your notes, to provide the identifying information for the client, who is this client, and to provide some observations about the client. Those observations being important because they're going to help us get a sense of whether or not this test is a valid assessment of his or her functioning. So what sort of identifying information? Well, you can record the test taker's name, age, sex or gender, education level, your name, and the date of testing. What types of observations? Well, make some suggestions here. Things like, what's the referral question? What do we know about the medical history of this person? What do we know about their presentation? What can we observe about their presentation? Do they seem focused and attentive? Do they seem distracted or confused? What do we know about their affect or emotions? Do they seem comfortable or anxious or depressed? What do we see in their behavior? What do we see in terms of their effort to complete all these tests that we're going to give them to do? As I noted a couple slides back, I think this information is important in part because you want to have a sense of whether or not the tests that you're administering are likely to be valid assessments or likely to yield valid assessments of neuropsychological functioning. If the person is disorganized or confused or just doesn't seem to be putting forth an effort, then it may not be worth really spending a lot of time trying to interpret these tests because they may not yield some very valid or useful information. On the front page, there's also a space to calculate age based on date of testing. That's important, of course, because scale scores on the different tests on the RBANS are determined with respect to age. Unlike those on the WAIS, we use whole years rather than years and months, and the ages are not rounded up to year. That's detailed in the back of the book, but just be aware of that if you're administering and scoring and interpreting this instrument. I think I say this on pretty much all of my lectures about using and interpreting tests. Don't forget to complete the information on the front page. Your memory won't improve with time. We don't need any neuropsychological testing to tell us that. You'll forget information, especially if you have lots of clients or if you have a busy clinical practice. So make sure you write that stuff down. Your notes are important. They're going to give you information that you can use when you're writing up your reports, helping to remind you of the important referral questions or the important medical background of your client, or, as I noted just a slide back, give you a sense of whether or not the tests you administered on the date of testing are likely to yield valid information, or they might yield invalid or misleading information. Okay, let's imagine you've completed the front page of the record form. You've then administered all the subtests on the RBANS, and now it's time to score up those subtests and begin your interpretation. Well, you begin, of course, with the raw scores from each of the subtests. These you just compute by adding up the various responses on the little tests, and you write them down on a page on the back of the record form that allows you to combine them to create index scores. So as we'll see in coming slides, particular subtests combine to give you index scores, and you can look up those index scores in a table in the back of the testing manual, and you can plot them to create a profile. I described this earlier, but one of the things that's nice about the RBANS is it yields a kind of a profile of different areas of neuropsychological functioning, which can be used sometimes for diagnostic purposes. Once you've done that, you combine all the index scores to give you a total score, and you can also plot the total score on a little scale on the front of the record form. So we use the raw subtest scores to get the index scores. How does that work? Well, we calculate raw subtest scores by summing up the items for each subtest, so summing up the points associated with the correct and incorrect responses on the little subtests, and then we transfer those total scores to a work page on the back of the record form called the score conversion page. Again, if you have a copy of the RBANS, you can flip to the back of the record form and take a look at what this looks like. If you don't, just imagine in your mind a little workspace where you can enter scores from each of the individual subtests on the RBANS. Now, to convert those subtest scores to index scores, you have to use a table that's located in the back of the stimulus book. The stimulus book is just the book that has some of the items for some of the subtests you need for the RBANS, and in the back it's got this appendix, as you can see there, and it's got this matrix that allows you to get scores associated get index scores associated with particular sets of subtest scores. So for instance, the immediate memory index score is found on a table which is a matrix for the list learning and the story memory subtest. You sort of look up your client's individual performance on each of those tests and find where they intersect, and that's the index score for your client for the immediate memory index. And you can also look up confidence intervals for those index scores. I'm a big fan of confidence intervals. Those are in in the same appendix, just on a different table. I have a little note here that these confidence intervals are often really wide because we're trying to estimate functioning in populations of people where functioning is quite variable. And so it shouldn't surprise us if those estimates are not quite so precise as we might hope. Once you've got that information, you can copy, and you can copy it to the front of the record form, and you can plot it for the little profile plot that I mentioned earlier. Next thing you do is you sum up those index scores, and you convert that sum to a total scale based again on a table in Appendix 2 of the stimulus book. So one of the things that's really nice about the RBANS is there's not a lot of hunting around you have to do to get the right tables and the right conversions. It's almost all in Appendix 2, and so it's pretty quick to do these kind of calculations and conversions that I'm describing. In fact, as I'm sitting here talking to you, it's almost more confusing for me to explain how to do it than if I could just show you if you were in my classroom. It's pretty easy. Once again, you can look up confidence intervals for the total scale. Those are in the back of the stimulus book as well, and you can copy and paste that to the front page. So now we're back on the front page. We've got our index scores for our different areas of neuropsychological functioning. We've got our total scale for overall neuropsychological functioning. What can we do with all this? Well, one thing we can do is a profile analysis. We can look at patterns of elevation and depression across those various indices and see if they tell us anything. Particularly see if they are similar to those types of profiles that we would see for prototypical neuropsychological cases. We can also go to the appropriate page in the record form and conduct some discrepancy analyses for our various indices, comparing, for instance, scores on the immediate memory index to the scores on the visual spatial constructional index, and so on. There are actually a lot of different comparisons that we can do, and we don't need to do all of them. Probably depends somewhat on the scope of our testing. What's the reason or the referral for the testing? What are the specific hypotheses that we're trying to evaluate, and so on. This is kind of like we saw when we looked at the waste. There are lots of little discrepancy analyses we could do between all the various subtests or all the various indices. Typically we don't need to do all of them. We just do the ones which are interesting or important to us based on the questions that we have or the hypotheses that we have. Okay, so to kind of sum it all up, we've got our information, we've got our scores converted from raw scores to index and total scores. We've plotted them as a profile, hopefully with some confidence intervals. We've maybe started to think about some discrepancy analyses. There are clearly a lot of different ways we could approach all this information. What should we choose? I've said this before, I'll say it again right now. I think it's useful to think of this in terms of successive levels of analysis or successive levels of interpretation, kind of the same general approach that I would advocate for almost any area of test interpretation. So what are those suggestions? How does this work? Well, we can begin at the overall level of ability. And here, what we're doing is we're looking at the total scale score for the person. So if we were going to write a report, we might begin by reporting and describing the total scale score for the RBANS. This is our assessment of the client or the subject's overall neurocognitive ability. And we might very well compare that overall neurocognitive ability to his or her general intellectual ability, that is, his or her intelligence, especially his or her premorbid intelligence, meaning what we think that person's intelligence was or their overall mental ability was before they were injured, if it's someone who suffered a brain injury, or before they became sick, if it's someone who suffered some sort of infection that damaged their nervous system, or before they started to show signs of dementia, if they're becoming demented, and so on. The RBANS is often used for dementia screening. I think I've mentioned that a couple times already, and so one of the first things we might do in interpreting the RBANS is look at that total scale score to get a sense of the person's overall neurocognitive ability and compare that to what we think their level of general intellectual ability was before they started to show signs of dementia. Dementia is this general group of disorders that are associated with gradual degeneration of cognitive abilities with accompanying changes in emotions and behavior. Alzheimer's disease or Alzheimer's dementia is one of the most common forms of dementia. I'm not exactly sure where I got these numbers. It's probably from the RBANS material, but estimates of maybe 50 to upwards of 70% of all dementia cases are Alzheimer's cases. And Alzheimer's disease is associated with loss of neurons in the cortex. In extreme cases, this loss can be seen with imaging, but testing can sometimes identify dementia long before the damage is severe enough to be visible on imaging. Certainly in very severe cases after the person has died, if we conduct an autopsy of the brain, we can see evidence of shrinking in different parts of the brain because of the loss of neurons. So in order to determine whether or not the person who we're testing is showing signs of dementia, we'd like to be able to compare their total scale score on the RBANS to their premorbid level of general intellectual ability, their premorbid level of intelligence. Well, how do we get information about what their premorbid general ability was? Well, sometimes, if we're lucky, we have some previous testing. So we have an intelligence test like the WAIS that was administered several years prior, and before the person started to show signs of dementia. And we figure that's probably a pretty good, that probably provides a pretty good estimate of their general intellectual ability. And we can use that as a comparison point. Do they show relatively low neuropsychological functioning today compared to what we think they would have given their relatively normal or even high level of general intellectual ability? So again, sometimes if we're lucky, we have an intelligence test that was from a few years ago, and it provides a good estimate of general intellectual ability. Of course, often we don't have that. Many adults don't regularly get intelligence tests. In fact, probably very few regularly get intelligence tests. I don't. So maybe the last time someone had an intelligence test, they were a child, and that was just decades and decades ago, so that's not useful. Or maybe they have an intelligence test, but it was lost, or we can't find it in the records. What can we do then? Well, in those situations, we sometimes use subtests from a battery that measures general intellectual ability, like the WAIS. So we might use the verbal subtest from the WAIS and get the verbal comprehension index, and use that as an estimate of someone's intelligence premorbid. How can we do that, or why do we do that? Well, verbal ability is thought to be associated with crystallized intelligence. Your ability to do well on those verbal subtests has a lot to do with what you know, words you know, pictures you recognize, the way you can manipulate language, and that's relatively stable over time as compared to fluid intelligence, your ability to learn new rules or think flexibly. So crystallized intelligence is thought to generally change a lot less with natural cognitive decline than fluid intelligence. Thus, if we give someone verbal subtests from the WAIS at more or less the same time that we're giving them the RBANS, we can use those verbal subtests as a guess, as an estimate as to what their pre-morbid level of general intellectual ability was. It's not perfect, but it's oftentimes the best we can do, or at least the best way we can gather that information. And if you think way back to the beginning of this lecture, you may recall that one of the things that the software for the RBANS allows you to do is use subtests from other test batteries, including the WAIS. And so no surprise there, one thing you could do if you had that software is you could administer the RBANS on your iPad and then quickly administer some verbal subtests from the WAIS as a way of estimating what the person's pre-morbid level of general intellectual ability is. Another way of thinking about or sort of estimating pre-morbid general intellectual ability is just to consider other sources of information. Those can include what we know about the person's education and career attainment, the reports that we can get from their friends and family. So, for instance, if we know that our client has an advanced degree, maybe he's a PhD in engineering, and for many years worked as a chemical engineer for a large engineering firm, we can guess that that person probably had above average level of intellectual ability because very few people have the intellectual horsepower to do that type of work. So nowadays, if we administer an RBANS to that person and we see a marked decline in overall neurocognitive functioning, that looks a lot like dementia. That person was very intelligent. Now she or he is showing very poor neurocognitive functioning. That looks like a steep decline. In contrast, if we know from someone's education and work record that they did not get very much schooling, that their career was more modest in terms of the intellectual demands they had, then it might not be the case. We might guess, and it is just a guess, we might guess that that person, in a sense, never really was all that intelligent, at least in the way that we would measure on a test like the WAIS. And thus, if we see low neurocognitive functioning now, that may reflect a decline, or it may reflect that there just never was a great deal of functioning there in the first place. Likewise, if we have reports from friends and family members that this person was always very sort of sharp-witted and intelligent and thoughtful in years and decades past, but in recent times has become much more quiet and withdrawn and confused, then that looks a lot like dementia. So we have different sources of information. It's often difficult to get a precise estimate of someone's pre-morbid level of general intellectual ability, but if we're thoughtful about using some verbal tests, if we're attentive to what we can learn from friends and family, if we look into the person's education and career attainment, we can often get a sense of whether or not the person was doing fairly well all along and now is becoming demented, or maybe they just were never particularly high functioning in terms of their overall ability. All of this is done to help us diagnose dementia, or what the DSM system now calls neurocognitive disorder. And to be clear, the symptoms and specifiers in the current version of the DSM are pretty complicated, but I'm trying to give you here sort of a general sense of how they work. In order to diagnose neurocognitive disorder, we'd like to see evidence of significant decline in neurocognitive ability. Again, if we have a particular client who used to be a chemical engineer and we know that she has a PhD and that she played piano and spoke 4 languages, and now on our RBANS that we administered today her functioning is overall very low, then that looks a lot like neurocognitive decline. In addition to that neurocognitive decline, we'd like to see evidence of impaired functioning, so impaired occupational and social functioning. Person's no longer able to participate in employment or in volunteer activities, is no longer able to socialize in the way that he or she, I guess I'm using a female example here, used to with friends and family. That's impairment in functioning. It's certainly possible that someone could have neurocognitive decline. Indeed, we're all going to have this eventually without a great deal of loss of functioning. That's okay. That's just life. That wouldn't be necessarily a diagnosable disorder. We'd also like to see this pattern of decline in functioning, decline in ability, impairment in functioning, not better explained by some other condition, like major depressive disorder, schizophrenia, and so on. So if we see that the person has severe alcohol dependence, and that we might even suspect that they were drunk the day that they took the test, well, that's probably a better explanation than dementia. Or if we know the person has been previously diagnosed with schizophrenia, it's certainly possible that they could also be suffering from dementia, but the schizophrenia at least provides a complication there. Or if the person's severely depressed, depression can be associated with impairments in memory and attention and other neurocognitive functions. So we want to try and rule out, if at all possible, those other conditions which could explain this pattern of symptoms and impairment in functioning. So to diagnose dementia, if we see a low total score, it may suggest a diagnosis, especially if that score is lower than we'd expect based on what we think their pre-morbid general ability is. And if we see that that pattern is degenerative. Again, the RBANS is a repeatable test, so we could imagine bringing someone in for testing and then bringing them back 6 months later or 12 months later. If we see that their function is yet further declined, then that looks like dementia. It looks like a pattern of degeneration in functioning, or a degeneration in ability, especially if we're also seeing co-occurring with that decreased functioning. The person is less able, even more so, less able to work or volunteer or participate or interact and so on. Important point here, often the most important thing you can do with a basic neuropsychological testing session is estimate overall neurocognitive ability. There's a lot more that can go into neuropsychological testing. There are often some very fine-grained questions that we can ask and try to answer. But in my judgment, I don't think I'm alone in this, one of the most important things is just to get that general sense of overall, what's this person's neurocognitive ability across different domains of functioning, like memory and attention and verbal processing and visual spatial processing. Overall, how are they doing? Fairly good, not so good, especially with respect to how we would expect they would do based on their pre-morbid level of functioning. Now, once we have that overall sense, we can sometimes move on to our next level of analysis and interpretation. That next level is at the level of is the index level. It's at the level of the index scores. So those particular scores for those particular areas of neurocognitive functioning, such as, for instance, memory. Now here, our job is to report and describe those indices, the constructs that contribute to someone's overall ability. And these are sometimes important for clinical interpretation, especially when we can see a profile or a pattern across different indices that resembles a prototypical neuropsychological case. So I'll describe what I mean by that in a few more slides, but first I want to highlight some of these different indices that are on the RBANS and talk about them just a little bit. First indices, or first index, I guess I should say, is immediate memory. And this is, as you might well guess, the ability to remember information over very short intervals of time. There are two subtests on the RBANS that contribute to this index. The list learning subtest, which is more or less what you guess if you've never seen it before, and a story memory subtest, which is involves reading a story to a person and having them repeat back different elements of the story. The emphasis here is on verbal inputs and outputs, meaning the input you're giving the client is you're speaking verbally to him or to her, and they're speaking back to you. Again, there's very little motor work on the RBANS, and that's by design. Next index is visual spatial / constructional, sort of an awkward term, but it involves it is based on two subtests, a figure copy subtest and a line orientation subtest, and it involves the ability to receive, to perceive, I should say, spatial relationships. Here, there is some motor input and output. So in addition to being able to process verbal information, the instructions of the task, the client has to be, or the test taker has to be able to do some motor work to copy a figure or to indicate which lines are correspond to which other lines that you're presenting to him or to her. Moving on, we've got our language index, and this is pretty obvious. It reflects the ability to respond verbally to known information, and it is based on two subtests, the picture naming and the semantic fluency subtest. So right here we can see elements from previous lectures. Picture naming is like a similar subtest on the Wechsler et al. Intelligence scale. Semantic fluency is like the controlled oral word association, or COAT neuropsych test that we've talked about briefly before. Here again we've got verbal inputs and outputs, and kind of like I mentioned earlier, this is the index and these are the subtests. They're probably closest to measuring crystallized intelligence. That is kind of how much information, or estimating how much information your brain has. Do you have good crystallized intelligence or relatively poor crystallized intelligence? Moving on, we have attention. This is the ability to hold and manipulate information. It is based on two subtests, the digit span and the coding subtest, which look fairly similar to the corresponding subtests on the Wechsler et al. Intelligence scale. They involve some verbal and also some visual and motor inputs and outputs. I should note here that they're not, in a sense, not really, this isn't really an index of attention. It almost feels more like an index of working memory. It's your ability to attend to information and then perform operations on it. So in order to solve the digit span items or to solve the coding subtest, you have to be able to attend to and remember and then manipulate in your mind simple information. So can kind of maybe think about it as a test of, as an index of working memory, or your ability to use memory to test attention. It's a little bit ambiguous if you ask me. And finally, we have delayed memory, and this is the ability to form relatively long-term memories. Long-term in the sense that by the time you're done, or as you're finishing up the test, you've started and about 20 minutes later you're almost done, you ask people to recall information from some of the previous subtests that you've given them. Like, recall that list of words that I gave you, or recall that story that I told you, or recall that figure that I asked you to copy and try and give it to me from memory. That's not very long-term memory. That's not months or days, or days or months or years or decades of your life. But it's longer term memory than the immediate memory index earlier. So as you could tell based on what I've already said, it involves some verbal outputs, also some visual and motor outputs, especially for the figure memory. Some important points here. No test can cleanly measure one and only one neurocognitive function. Each subtest and each index that is based on two subtests requires multiple functions, and the differences really are probably more a matter of emphasis than absolute distinction. Right? So if I say I've got an attention index, there is attention that is being evaluated by the subtest on that index, but as I noted, there's probably also some amount of working memory. The goal here isn't to sort of cleanly divide the workings of the mind into these little boxes of like immediate memory, delayed memory, attention, visual, spatial, constructional, etc. We do that, but we acknowledge that there's a certain amount of blurring at the margins or overlap. No battery of neurocognitive functionings can assess, or no neuropsychological battery can assess all neurocognitive functioning. So there's a lot that the RBANS doesn't measure, or doesn't measure probably as well as other batteries of tests could measure, because it was designed to be quick and easy and useful. It's designed to give us a very broad assessment of some different important areas. So if you take these different indices like language and visual spatial construction and attention and different forms of memory, and if you keep those in mind, if you hold them in memory and then refer back to some of the previous lectures I've done, you'll see that they kind of map onto our information processing model of neuropsychology, and that's by design. The RBANS is supposed to hit those broad areas, and it's also supposed to hit them or measure them in a way that is useful for screening and for tracking functioning, and sometimes for diagnosing clients. Now, I've mentioned diagnosis a bunch of different times, and the RBANS is designed to aid in diagnosis through profile analysis, again looking at patterns of elevation and depression across various indices. And they may suggest diagnosis in some cases if your client's pattern of indices, the ups and downs on her profile, resemble the ups and downs on the profiles of prototypical neuropsychological cases. One of those I've already mentioned before, Alzheimer's disease. Now, Alzheimer's disease is probably the most common form of dementia, and it is associated with a degeneration in neurocognitive ability and associated degradation in functioning. If we want to get a little bit more specific about it, we could say that Alzheimer's disease is associated with anterior grade memory deficits that are most common early and are the most clinically significant feature. It also is sometimes associated with language deficits, but less often is it associated with visual, spatial, and attentional deficits. So you can imagine, or you can get the sense right there, there's kind of a profile of losses. We don't see just all across the board losses. We see losses more in some areas, memory, and less so in other areas, visual, spatial, functioning, and attention. Another form of dementia, distinct from Alzheimer's disease dementia, is vascular dementia. Vascular dementia can occur when there's blockage or damage to cerebrovascular systems that leads to loss of blood perfusion in surrounding brain areas and results in death and damage in those areas. Now, the death and damage in those areas depends on which part of the cerebrovascular system is blocked or damaged. So clearly, where the block occurs or where the damage occurs is going to dictate the parts of the brain that are damaged or die as a result. However, if we look at cases of vascular dementia, we can generally say that damage to subcortical areas is somewhat more common than damage to cortical areas. So if you're going to see blockage or damage, it's most likely to affect subcortical areas, relatively speaking, than cortical areas. And the pattern of deficits we see in neurocognitive functioning tend to emphasize loss of visual, spatial, motor, and attention deficits, less so memory deficits. So again, we get a sense of a slightly different profile for this type of dementia. Again, it's not everything is down, it's that some areas are down more than others. I mentioned, I think in one of my previous lectures, there's also a pattern of dementia called multi-infarct vascular dementia. This is where there are thought to be many small infarct events and damage over time, and this can be particularly difficult to diagnose, to recognize and to diagnose. So rather than having one big stroke event, a person may have many micro strokes over time, and this can lead to sort of a general pattern of loss of functioning in different areas that can be kind of difficult to differentiate entirely. Okay, so let's try and put this together when we're trying to work on our diagnostics. If we suspect dementia, we might begin by noting that the person, our client, has relatively low total scale score. So their overall neurocognitive functioning is relatively low given what we might expect based on our best guess at their premorbid ability, and that's based on what we can gather from friends and family and knowledge of that person's education and career, and maybe if we're lucky, a good intelligence test that was given in the past. Also, if we're seeing a pattern of loss of functioning, that looks like dementia generally. Well, what sort of dementia? It may not be entirely possible to pin it down, but what we can do is look at that RBANS profile to see if it's more likely to be a cortical or form of dementia, particularly Alzheimer's disease, or a subcortical form of dementia, particularly vascular dementia. And to be clear though, this distinction isn't always precise, and it's possible someone could have both Alzheimer's disease and vascular dementia, or a pattern of multi-infarct dementia, which could kind of blur everything together. So to be clear, generally there's evidence of dementia, and if we look more closely, it kind of looks a bit more like Alzheimer's disease, or does it look a bit more like vascular dementia? And I've said profile analysis a bunch of times, so I feel like I gotta show you a profile. I guess two profiles here. These are two kind of prototypical cases. One is vascular dementia in the kind of green triangles. The other is Alzheimer's disease in the black diamonds. And you can see that both are associated with relatively low overall functioning. 100 would be the mean. And so these are, both of these clients have low functioning across the board. But we see that in the case of Alzheimer's disease, there's this big dip in the memory area for immediate memory and especially for delayed memory. In the case of vascular dementia, there's a relative dip as compared to the Alzheimer's disease in visual spatial constructional. So we see a slightly different profile for these two prototypical cases. Sometimes to make this more clear, if we're using scoring software, or even if we can just do this by hand, we can compute cortical, subcortical deviation scores by subtracting delayed memory and language from visual spatial functioning and attention. And if we do that, we see a kind of a deviation score such that an elevation makes it look more like a cortical dementia, Alzheimer's disease, and a depression makes it look more like a subcortical dementia, vascular dementia. So that's sometimes, if you have a hard time kind of squinting at profiles, you can do a quick bit of math and you can get a cortical subcortical deviation score, and that can suggest, oh, this case looks a bit more like a cortical dementia, looks a bit more like a subcortical dementia. So again, Alzheimer's disease is a cortical dementia because visual, spatial, and attention indices, which refer to subcortical functions, are relatively strong, at least as compared to subcortical dementia. Delayed memory and language, which are cortical functions, are relatively weak, and this produces, again, that positive deviation, making it look more like a cortical dementia. Vascular dementia is a subcortical dementia, usually, though not always, because visual, spatial, and attention, which are subcortical functions, are relatively weak. And delayed memory and language, which are cortical functions, are relatively strong, producing a negative deviation score, making you think, this is more consistent with a kind of a subcortical dementia. Maybe it's vascular dementia. Pardon me. Getting over a cold here, so I'm coughing a little bit. Hopefully you heard that last bit. So important point here, this differential diagnosis isn't always easy. Particularly vascular dementias are tricky to identify, and there aren't always subcortical in their presentation. But if we're suspicious of them, if we think, gosh, this person might have a subcortical dementia, it sort of looks like they have that negative deviation score, we probably already should have asked them about their medical history. If their medical history is positive for heart disease or positive for stroke, then we think, oh, well, that definitely looks like it's adding evidence or making us feel more confident in a vascular dementia diagnosis. Another important point, the RBANS is really more helpful for Alzheimer's screening. Alzheimer's tends to be more common anyway, but Alzheimer's screening can be usefully accomplished if we can identify those memory and language deficits. So if we see someone who's got evidence of dementia, and if we see that dementia seems to be principally or most strongly in the area of memory and language, then that looks like Alzheimer's disease more than it looks like other forms of dementia, at least more than it looks like subcortical dementia. So where the RBANS probably really shines is it helps us to identify dementia, and maybe particularly to identify if it's likely to be Alzheimer's disease. So I've been mentioning so far Alzheimer's disease and vascular dementia. You may be wondering, well, what about other forms of dementia? Dementia is this kind of collection of different disorders which are associated with loss of neurocognitive ability and related declines in social and occupational functioning. There are clearly other forms of dementia. What about them? Well, the updated version of the RBANS has some additional diagnostics built into it, including information on Huntington's disease or Huntington's dementia. This is a relatively rare form of dementia that involves loss of neurons throughout the brain in both cortical and then in first subcortical and then in cortical areas. In the case of Huntington's disease, we usually do genetic testing to detect it if we think that the person's at risk, because this is a disease that's autosomal dominant and so it will run in families. You probably wouldn't do the RBANS to detect Huntington's disease, though you might, but you would use the RBANS or a similar sort of test to monitor its progress. Again, the RBANS is repeatable at least up to 4 times before you'd have to start recycling versions of the test, and so you might administer the RBANS across 4 years of time to track the progress or the loss of abilities in these different areas. In the case of Huntington's disease, we see subcortical deficits that are fairly common early on. So losses occur in subcortical areas like visual, spatial, and motor and attention typically first, and then later on language. Indeed, this is, all of these dimensions, of course, are really challenging for the patients who suffer from them and for their families, and gosh, they're sad situations. The goal of our testing is to identify them. In some cases, Huntington's disease is particularly sad because people who have it often have very good intact language functioning quite well along the way, and so they're aware and they're able to describe some of this loss of functioning, and again, it can be really hard for them and also for their families as well. Here's another profile graph, and you can see here a comparison of Alzheimer's and Huntington's dementia and also normal controls. So you can see normal control in the white boxes or white squares. Their overall functioning is right around average, a little bit above average actually, because they're 110. And if we look at our 2 dementia cases, they're below average overall. In the case of Huntington's disease, the language, their overall functioning is relatively low across the board. We don't see these relatively large dips. In the case of Alzheimer's disease, the biggest dips are in the area of memory. So that's very sort of classic for Alzheimer's disease. Huntington's disease is a little more like everything's gone down. The subcortical stuff like attention's particularly down. The cortical stuff like language is relatively speaking up. So that, again, you could imagine if you just had the Huntington's disease profile, it wouldn't necessarily tell you, oh, this is Huntington's disease. But if you could compare it to like an Alzheimer's disease profile, you might say, well, it's a dementia, it's probably not Alzheimer's disease, and we already know this person has a family history of Huntington's, so it might be the Huntington's, and we should probably recommend genetic testing if the person hasn't already undergone testing for it. Here are some more of those subcortical deviation calculations, and you can just see that, again, this is going to look different patient to patient to patient, but relatively speaking, with Huntington's disease, we get more of the subcortical deviation kind of shift rather than with Alzheimer's. And you can also see here some other things, some other plots as well. Okay, suggesting a diagnosis. The RBANS-Update in its current version includes norms for these disorders. It also includes some other norms for other disorders, so Parkinson's disease, HIV, associated dementia, schizophrenia, chronic depression. I think that those are very interesting, and traumatic brain injury. So it's not that you can be entirely sure to differentially diagnose these conditions based on just the RBANS, but they can be useful for helping to further your assessment or helping to track functioning over time. If you're working with someone who you know has suffered from a traumatic brain injury, you can get a sense of how well they are doing relative to a patient population who's also suffered that injury. If you have a client who you know has been diagnosed with schizophrenia, you can see how good or how poor his or her functioning is compared to a patient population or client population of people with schizophrenia and so on. So the RBANS-Update, I really like that in the update they've added these norms. It makes the instrument, or I should say the battery tests, very useful for a clinician. Also, what's really neat about the RBANS-Update is that they've added norms that extend all the way down into adolescence. if I'm not mistaken, and again, it's funny to talk about memory when it's funny to query your own memory when you're doing a lecture on neuropsychological assessment. It feels like, oh no, am I suffering memory problems now? But as I remember it, the earlier version of the RBANS only had norms that went down to, I think, age 50 or maybe age 40. Now the RBANS-Update includes norms for much younger ages, which is really useful because, sadly, people can suffer from neurocognitive problems at a variety of ages. Traumatic brain injuries associated with sports or military service, or just accidents can occur at younger ages, as can depression. Schizophrenia typically onsets in late adolescence or early 20s, so we'd like to be able to monitor that if possible at younger ages. Parkinson's disease can onset in the 40s, so it's nice to have those younger age range norms as well. A couple more important points. Profile analysis with discrepancy analysis is really the main focus of RBAN interpretation. Interpretations don't always lead to diagnoses, but they can be helpful for adding information and for suggesting further testing. So the RBANS as a battery is really, I think, best thought of as a screening battery and as something which can provide some hints, which you can hopefully follow up with with more testing. And as I've said now a few times, the RBANS is also really useful because you can repeat it at least a few times to track changes. And for most of the diseases we've talked about, pretty much all of them, we expect change over time, and we'd like to be able to monitor that. The RBANS is a great tool to allow that. Okay, so now we're all the way down to the most kind of fine-grained, the subtests themselves. Here, there's not as much we can do because the subtests, we have relatively limited information from each individual subtest. There's not a lot of analyses we can do on them. To repeat myself a little bit, subtest level analyses are difficult to do. There isn't a lot of information to work with because the subtests themselves are short. One of the things that's nice about the RBANS is you can get through the whole thing in 20 or 30 minutes. That's good, usually at least. One of the bad things about the RBANS is it's so quick because it's so short. And you should remember that any short measure is going to be less reliable than a relatively longer measure. So whether we're talking about personality tests or intelligence tests or neuropsych tests, short tests give less information and are less reliable. It's also worth noting that the index scores for the RBANS are each computed based on 2 and only 2 subtests. So, that's just not a lot of information to work with. However, if you really want to, you can do some discrepancy analyses. You can convert the raw scores from each of your subtests to scaled scores using the stimulus book. And then you can report and describe performance on these individual subtests. And you can ask, you can ask the question, are these patterns of performance interesting or clinically meaningful? Again, be careful about being speculative here. Consider other sources of information. If you note that there's a particularly interesting pattern of poor performance on the attentions, one of the attention subtests, you might report it if it corresponds to some sort of other information that you have about the client. So you might note, for instance, that, well, this person on their attention subtest for digit span did really poorly, and it's been noted by the client's family members that this person has a difficult time remembering their phone number. All right, well, I'm not sure if the test has added a lot of information that you didn't already have, but it sort of matches up. Likewise, you might look at someone's ability on the semantic fluency task. Maybe they have very limited semantic fluency, and that's much lower than other tests across the board. Maybe that's interesting, especially if it matches up with clinical observations that you've made where the person seems to struggle to produce language when answering basic questions. Hi, how are you? What brings you here to my office today, and so on. That subtest level, I think, can be useful provided that you're able to resist the urge to be too speculative and instead try to connect connect information you're getting from the test with information you can get elsewhere, and think like a scientist practitioner. Use your hypothesis testing approach. If you have a hypothesis about the client, can you use the information from the subtests to test or to evaluate that hypothesis? Okay, so to conclude, let's put all of this information together. It's an awful lot to take in, and you may feel a bit overwhelmed by the whole process, but just try to remember the basic approach that I teach and that I have taught for all the other tests. Begin with the overall level. Does this person have a deficit or decreased overall neurocognitive functioning? Move down to the index level. Does the pattern across different indices in these broad areas of neurocognitive functioning correspond to a prototypical pattern from known types of diagnoses? Sometimes it will, sometimes it won't. And then if you need to, or if it's really clinically relevant, perhaps consider analyzing at the subtest level, looking at discrepancies between individual subtests or comparisons between individual subtests and overall functioning and so on. Although again, that's for the RBANS a little bit less often the focus. And most importantly, remember that the test, this battery of tests, the RBANS, is just one source of information, and it should connect to other sources of information as part of your full and complete assessment. Don't mistake the test for the assessment. The test is a tool, the assessment is the product that you, the skilled, trained, and licensed mental health professional, make with the tool. Okay, that's all for now. Thanks for your sustained attention over all of this lecture. We're clocking in at just over an hour, so it's a pretty long lecture. I appreciate you sticking with me. I hope you've learned something about the RBANS, and I'll be back soon with some more stuff on neuropsych testing, and also, yeah, I've got a couple more lectures in me, I think. If you have questions, post them on the YouTube comment area. I'll do my best to answer them. Thanks so much. Take care. Bye-bye.